Welcome to Adapt NCLEX. Today we're going to be talking about NCLEX fundamentals using case study, using hip arthroplasty, 10 fundamental questions, how to answer these kind of questions. You will see fundamentals very important. So let's get to it. Straightforward question, but we're going to use critical thinking to answer these questions regarding a hip arthroplasty. Basically, from fundamentals all out. So you have a 72-year-old man on the orthopedic ward. What do you think, right? Orthopedic ward, there's a reason why I give you a 72-year-old. The patient was admitted, had a total hip arthroplasty. So that is your buzzword. Patient had arthroplasty, right? What is the problem? Patient has history of what? Hypertension, diabetes, and guess what? Latex allergy and morphine. These are key. There's a reason why they put it in the case study. On the NCLEX, they'll put it in the sentence. You have to go for them, find them. In the first two sentences of every case study, there's something that will give you chief complaint. This patient has no chief complaint. He just had surgery, has been admitted to the orthopedic ward, and these are the information about the patient. Can you figure out what you need to do about this patient? It's a post-op management of hip arthroplasty. Bring your content to answer the question regarding this patient. These are the patient's vitals. You can see temperature, blood pressure, heart rate, respiratory rate, and saturation. Does that concern you? If you're taking care of this patient, what do you think? Should you worry about this information? Think about that. And these are the patient lab. Glucose 132, hemoglobin 11.2, and WBC 11,000. Patient is post-op, admitted to the ward, orthopedic ward, and these are the initial information you find. Should you worry about it? It's a case study. Synthesize every information. These are critical judgment. Most cases require you to do critical judgment, put everything together. Not everything is important, but you have to put it together. So this is what I've given you. Think about it. 72-year-old, just had surgery, had multiple medical problems and multiple allergies. These are the vitals and these are the lab work. Now, post-op day one, these are the orders you have. Patient is on IV fluid, NS at 75. The Foley is in place, is draining appropriately, right? Surgical drain, you should expect the patient to have surgical drain for hip arthroplasty. And what is coming in the drain? 80 ml of serosanguinous output. Serosanguinous output is like a Kool-Aid. That is no bleeding. Don't worry about it, okay? Now, this is the first question you saw. If you're taking this test, this is what you see. What do you want to do? Which client finding indicate a need for additional assessment? Based on the case that we saw, is the Foley in place? Is it a problem for you? The surgical drain output put at 80 ml in 24 hours. Should that bother you? If it bothers you, you put it that, and you can put that in the comment section and we can all talk about it. Patient has a latex allergy. Should that bother you? If the WBC is 11,000, should you worry about it? The heart rate is 92. Should you worry about it? And the client is reporting increasing pain at surgical site. Which of these should worry you? Which of these need additional assessment? Which of these do you think need additional assessment? What do you think? Which of these need additional assessment? Foley, surgical drainage, what? Latest allergy, the WBC of 11,000, heart rate of 92, and a client increasing pain at surgical site. You can see Foley, there's nothing wrong with it. There's nothing benign. The patient needs Foley, so we have Foley in place. Surgical drain output of 80, that is fine. There's nothing wrong with it. It's serosanguinous. The output is not bleeding. Latest allergy is worrisome, right? Because of in the post-op setting, there's so many multiple interventions, you forget, and then you go and waste something that will affect the patient. So latest allergy is a problem. The WBC of 11,000 is okay, right? Post-op day one, inflammation after surgery, your temperature will go up a little bit post-op. The right immediately post-op is not a problem. And a heart rate of 92 is still in the same range. But client is having more pain, right? Increasing pain at the surgical site is worrisome. So the only two things that we should worry about is the latest allergy and the client report increasing pain at surgical site. Now, think about it. This is the problem. What is the most concerning risk for this patient based on history and current condition? The story is he had a hip arthroplasty. He's an older guy. He just had surgery. Which of these conditions should you worry about? Pressure injury. Should you? Post-op hemorrhage, bleeding, prioritization. So this is a prioritization, right? Deep vein thrombosis. Should you worry about it? Hypoglycemia. If you see this on the NCLEX, what are you going to choose? Which answer choice are you going to choose? You can put that in the comment and explain your answer. Do you think pressure injury is the problem for this patient, or post-op hemorrhage, or DVT, or hypoglycemia? I have something called B-sharp. In the B-sharp, you got to worry about breathing problem, electrolyte, shock, sepsis, airway, and pain, right? We have hypoglycemic in it, right? We have DVT, which is pulmonary problem. We have shock, which is hemorrhage. We have pressure injury. That can be like a pain, right? But which of this do you think is you should prioritize? What should the nurse worry about? Pressure injury, we can deal with it later on. Patient just had surgery, so I'm not worried. We try to move them. Post-op hemorrhage, yeah, I should worry about it. But the drain putting out serous fluid, why should I worry about it? DVT, well, it's going to kill him right away, right? Airway problem. Hypoglycemia, we can check it. The patient is diabetic, his glucose is like 132. I'm not worried about it. So C is your friend. Now, you have to rank this information, order step, which complication is to the most to the list. So which one is more serious and which one is not? So this is what you have. Surgical site infection, impaired mobility, DVT, pain, and urinary retention. If you're taking care of this patient, I want you to go clinically. Which of these do you rank number one? So which one is going to be number one? Which of this will you rank as number one? Is it DVT or impaired mobility or DVT, pain, or urinary retention? Of course, urinary retention cannot be number one. Pain cannot be number one if you're doing prioritization, right? Pain is not going to kill you. It will help with mobility, but it's not going to kill you. The one that is going to kill you is your priority, which is the DVT, right? Followed by sepsis, right? So number three is number one, followed by number one, which is surgical infection, before you can address the psychological need, which is pain, right? Then mobility, before urinary retention. So the first thing is number three. So it's 3, 1, before 4, and 2, and 5. Once again, 3 is number one, DVT. 2 is infection, right? Infection. 3, you got to worry about their pain. And the 4, you got to move them. Impaired mobility is a problem. It can cause problem. And then 5, before urinary retention. That's the order at which you should worry about. So ranging them in order, it has to be DVT, surgical infection, pain, impaired mobility, and urinary retention. Now, this same patient, which nursing action is best to reduce client risk of respiratory complication? I'm just walking you through the process of fundamentals post-op arthroplasty, so that when you see a patient, they see a case, these are the things you care about. We worry about certain things. There's certain things we can do to prevent complication. This is classic fundamental nursing care. If I want to reduce risks of what? Respiratory complication, should I elevate the client's head? Is it important? Should I encourage them to use incentive spirometer? Which one is better? Should I apply compression stocking to prevent something? I don't know. Or monitor their oxygen saturation every 8 hours. What do you think? Which of these will help reduce what? Respiratory complication. Respiratory complication. That means you have to do something, right? The patient actively has to do something rather than providing them something. Even if you provide them something, you have to give the equipment to do something to prevent respiratory complication, right? There has to be active involvement. Applying certain things on them sometimes doesn't do that. So active involvement, you elevate their leg ahead, they don't involve, they don't do any active involvement. Using incentive spirometer means they're doing active involvement. They expanding their lung, they're bringing air, taking away all respiratory athleticism is much better than just elevating their head. Compression stocking is going to prevent edema, but that is no more important than athleticism at this time. Giving them oxygen, you're just making them lazy. They can't do anything anymore. So number 3, incentive spirometer is the best answer. Now, for each potential prescription, that's the provider is going to order something. Indicate if the prescription is expected or not expected. You see this all the time in cases you're doing. Go back to the problem. What does the patient have? He has post-op what? Arthroplasty. We want to prevent complication. We should know what to do with these patients. So what do you think? Restrict patient fluid, give them low fiber diet, give them stool softener, anticoagulation, apply adductor wedge, check their neurovascular check every 4 hours, and then incentive spirometer 10 times every 4 hours or a week. Haven't you seen these questions multiple times? Now it's in the form of a case study about post-op patient. They can give you any post-op patient. These are little things they will put there because this is what we do in nursing care. What do you think? Should we restrict fluid in these patients? Should we lower their fiber in their diet, give them stool softener, anticoagulation, and apply adductor wedge or neurovascular check every 4 hours or incentive spirometer? You have to choose something at each block. For this one, you got to choose something, right? So what are we going to choose? What are we going to choose? We got to choose something. Of course, we're not going to restrict their fluid. It's not expected, right? Low fiber diet, they're going to have constipation. Why do we do that? No. We should give them stool softener because they're going to have pain medication. They're not going to be moving along, and they're going to have pain and slow down in their GI tract, and they will have constipation. They will need anticoagulation to prevent DVT, right? This is a trap, adductor wedge. The idea is to prevent hip dislocation. So don't bring the two legs together. The hip should be far apart. They should stay away from each other. They should never come closer. And how do that? When you bring them together, you are adding things. You are adding adductor wedge. But when you pull them apart, subtraction, ABD. So ADD is addition. We should not do that. Right? Neurovascular check every 4 hours is good. And the last one is a trap. You see incentive spirometer, then you pick the answer. If you don't look at it carefully, NCLEX will do that to you. Attention to details. This is what it is. Attention to details help answer question critically and make you gain points. You don't do incentive spirometer 10 times every 4 hours, right? You do it 10 times every hour. So within an hour, you got to do it 10 times. 10 times every 4 hours, that's too much. That's less than what you need, right? And that will cause problem. So this one, not expected. Even though we need incentive spirometer, the number of times patient is doing it is inappropriate. It's 10 times every hour. or 10 times every 2 hours at least, but 4 hours is not okay. At least 10 times every 2 hours, but not every 4 hours. It's not okay at this point. So these are the expected, unexpected things that you will see, right? So now we're going to match each post-op order with the correct rationale. Why are we doing this? We're trying to save the patient. But every order that we give to a patient, there's a reason why. Outcome, right? Nursing assessment. We come up with a plan. We give the patient a plan, and we will evaluate outcome. So what is the rationale of doing all these things? That's all. So this is the orders. Incentive spirometer every hour. We're giving them enoxaparin, neurovascular check every 4 hours, and we're going to advise their diet as related. Well, what is the reason why you're doing it? One, assess GI motility, promote lung function, prevent thromboembolism, and monitor for circulation. So pair the order and the rationale. What do you think? I know you know it because you watch adapting class. So what do you think? You can put in your answer choice, right? Why are we giving incentive spirometer? It's because lung function, right? Why are we giving them enoxaparin? What do you think? Why do I give it to you? I want to prevent thromboembolism. Why am I checking neurovascular check? Because I want to check your circulation and nerve damage during the procedure. And I advise your diet to ensure, as related, to make sure your GI motility, right, is waking up. We don't just slam you on regular food right after surgery. We give you diet, advise you clear liquid, full liquid, and then regular diet. We are assessing GI motility post anesthesia because everything slowed down. That is the purpose. So that's the pairing. It's a straightforward question testing your fundamentals, right? And I know you know it. Which finding indicate that the plan of care is effective, right? Effective assessment of the plan of care that was instituted. What do you think? Surgical draining output has decreased to 25. What do you think about it? Client report pain relief after using incentive spirometer, right? It's doing better. His blood glucose is now 160. Is he okay? He started 132. He can ambulate 10 feet with the walker without any pain, just a minimum pain. Is that good? And the Foley is just draining clear liquid, clear urine, basically. As you can see, the surgical drainage is decreasing. We are doing good. The client is using incentive spirometer and no pain. He's doing good. His glucose is going up. I don't like it. It may be infection. 3 is bad. He can walk 10 feet. That's good. No minimal pain. That's good. And the Foley is just draining. So he's well hydrated. He's walking. His pain is much better. I think he's ready to go home. So 1, 2, 4, and 5 are okay. This is a select of the plan. NCLEX, you don't have to pick everything. Pick those you're confident. You don't want to lose points, but gain points. If they give you see 4 answer choice there, and you know the 3, pick the 3 and walk away. Walk away. Now, no more hate. Which of the following findings indicate improved outcome and need for further assessment? So either it shows patient is doing better or we need assessment. And is the continuation of the 7. You can see this kind of variation of question they may ask you. They're trying to trick you. You said, I've already answered that portion, but it's the same thing. It's a concept telling you what you look for. So this is the first. Client uses incentive spirometer independently, right? First, he uses it, and then the pain is getting better. Now he can do it on his own. He doesn't need help with the nurse to help him. His blood glucose is now 240. You think he needs further assessment on that, or he has improved? He can ambulate now with just a little assistance, right? He still can ambulate. We removed the Foley catheter, and he was able to void 350. Is he doing okay? And then he report incisional pain now 8 out of 10. And there's drainage from the drain. Initially, it was what, 20? Now we are pouring into drainage. Which one need further assessment and which one need improvement? Fundamentals. You have to bring all the things you need. fundamentals of nursing, taking care of post-operative patient, questions and answers in a practice case study. What do you do? Independent case study. And you can see how the walkthrough, it makes sense through. Patient is using incentive spirometer independently, is doing fine. His blood glucose 240 is a sign of infection. That should trigger something. Diabetes patient post-op with increased glucose is a sign of infection. He can ambulate with assistant. That is okay. They usually are not 100%. Ambulating with assistant is a good thing. His Foley was removed and he put out like 250, 350. He's doing good. His pain has increased. That's not good. Something is not going well. That's why it's all consistent with signs of infection. Glucose up, more pain, and a drainage is prevalent. That need further assessment. That the nurse need to do something about it. Therefore, if the patient needs further assessment, what did the nurse do? Look at what she did. She decided, well, delegate some things to the UAP, and he saw the UAP doing things. Instead of making sure we take care of the infection, this is what she saw the UAP. So which action by the UAP requires the nurse to intervene? She's mad. She said, well, what are you doing? Patient is having infection. Now you're trying to do all these things. Assisting the client to use the incentive spirometer every 2 hours, helping the client sit up at the bedside before ambulating, placing a pillow between the client's leg while turning them, repositioning the client by pulling them up in bed using a draw sheet, and elevating the operative leg on the 2 pillows to prevent swelling. I take the concept of hip arthroplasty and I figure out every question they will ask you when you get this case study, either case study or standalone, musculoskeletal on hip arthroplasty. If you watch this video there's no question that you can mix because these are content and this is like you can watch this video and you know everything about hip arthroplasty. This answer choice is what they will put there. What do you think? The UAP did something that you should not do post-op management on a patient who have hip arthroplasty. What do you think? You can put it down in the comment. But this is something is good to know so that when you see a standalone question or you study about hip arthroplasty, what are the risk reduction information you need to know that you think the NCLEX will ask you? One is okay. It's okay to teach them every 2 hours, every hour at least. That's fine. Helping the client sit up at bed before ambulating, yeah, so that they don't fall. It's within the scope of practice, right? Right. Of the UAP. Placing a pillow between the client's leg while turning them is to prevent hip dislocation. Precaution. He's taking hip precaution. This prevent what? A, B, or AB. What is she trying to do? She does not want to bring the 2 legs. So addition, she wants to prevent adduction. So that's a good thing. But when she repositioned the client by pulling them up in bed using the draw sheet, there's no precaution. And this will lead to what? Hip dislocation. You should not do that. And how about the last one? This is a good one to know. That elevate the operative leg on the 2 pillows to prevent swelling is a trap. Once again, is a trap. Don't do that. Elevating the operative leg on the 2 pillows will lead to what? Hip contraction, right? Flexure contraction. We don't want that. You can put the pillow under what? The calf and the foot, but not the operative side. Don't know this question. They should never put it under the operative side. They should put it under the heel or the calf, the foot. And otherwise, this will lead to what? Flexure contraction. Therefore, 4 and 5, the nurse should intervene. That's a bad thing. And the last one, for the road, which client is ready for discharge. Which teaching is appropriate? What is the nurse going to do? This is all you have. I've given you everything. Look at it. Select what you think teaching is appropriate. This is teaching regarding hip arthroplasty. This is fundamentals of nursing. Things that is good to know when it comes to teaching a patient after hip arthroplasty. Guess what? This is common. A lot of people have it. Don't you think you should know about it? Because the NCLEX is going to ask you. What do you think? Give the enoxaparin injection in the thigh at 90 degrees. This is a concept. It's good to know. Inspect what? Incision daily for drainage and swelling. Is it a bad thing to tell a patient that? Ensure the toilet seat is positioned closer to the ground. I'm just trying to trap you, right? Which install grab bar in the house? What do you think? Which use is recommended for the next 2 to 3 weeks? Is that true? Cross your leg while sitting to prevent blood clot. What do you think? Remove all area rags. Is it a good teaching? Mobility exercise as prescribed. And what? Perform ankle pumps regularly. Which of this? You have 9 answer choices. You don't have to pick everything if you don't know them, but pick those that you know you're confident about. But if you answer the question, at the same time, it's little things you already know. I'm just grabbing it from you. So if you watch this video, stop the video, try to answer it, and see how many do you got. 9 points. Not all of them are right. I can tell you that. Some of them are trap. Therefore, what do you think? The first one is a trap. It's a concept. Enoxaparin is injected with sub-Q. Sub-Q injection is not 90 degrees, right? Unless the patient is big, right? Obesity, right? Usually 45 degrees. But if I want you to do that, not in the thigh either, right? Fat. There's no a bunch of fat in your leg. Most of the time, where there is what? A lot of fat, right? It's subcutaneous. Injected it in your thigh 90 degrees is going deep into the muscle. It's not intramuscular injection. Inspect incision daily for drainage is good. Ensure the toilet seat is positioned closer to the ground is a trap. What you teach patients after hip arthroplasty is to elevate their toilet seat to prevent flushing and dislocation. So they need to have extra toilet seat elevate, have additional device that can elevate their toilet seat. So that teaching is wrong. Grabber is good so that you don't fall, right? Which is recommended for the next 2 to 3 weeks? Guys, what do you think? You can put it in the comment. Do you think this patient needs wheelchair for 2 to 3 weeks? It's a trap. The key is if you're not walking, you are not going home. Once again, concept. That's the mnemonic or whatever you want to call it, but that's the trap. Any patient who has hip arthroplasty, if you cannot walk with assistant or with a cane or something like that, you are not going home. Wheelchair is a trap. They're not going to use wheelchair. They have to walk out of the hospital. Cross your leg while sitting to prevent blood clot. That's also a trap. They should not cross their leg because that will cause what? Hip dislocation. That's a trap also. Remove all area rags is to prevent you from falling. So that's good. Mobility exercise as prescribed. That's good so that you can move your leg to prevent DVT. And the last one, if you don't know it, I just use words to trap you. NCLEX will do that. Perform ankle pumps regularly. Ankle pump is like you're driving a car. You push on the gas up and down. So your leg go up and down. When your leg go up and down, you're moving blood back to your leg. Circulation. And they're doing exercise, ankle calf exercise to prevent DVT. So that's good. So which teaching is good? Number 2 is good. Inspect the incision. Number 4, install grab bars. Number 7, remove all area rags. Number 8, mobility exercise and perform ankle pump. This is NCLEX Fundamentals, post-op hip arthroplasty. Thank you for watching, and I hope you learned something. If you like this video, share it with your friends. This is something you have to know. I have to go through a case study. Thank you for your time and all the best of luck.